Imagine going to a specialist because you're experiencing vaginal prolapse.
Right.
It's uncomfortable, it's distressing, and you just want to talk about your surgical or, clinical options.
Of course you want to plan.
Exactly. But the very first thing your doctor tells you to do is stop coughing.
Yeah, which sounds completely absurd at first.
It makes literally zero sense on the surface. I mean, we're so used to compartmentalizing our bodies. Like, if you have a knee problem, someone looks at your knee.
And if you have a pelvic problem, someone looks at your pelvis. It's a very natural way to view the body.
Right.
We divide medicine into all these neat little specialties. But human anatomy completely ignores those artificial boundaries
It really does.
because the body actually operates as a closed ecosystem of pressure.
And when that pressure ecosystem gets thrown out of balance, the results are just wild. So, welcome to today's deep dive.
We've got a really interesting one today.
We do. For you, our curious listener, we have a fascinating stack of sources to go through. We're looking at clinical statements from the British Thoracic Society, NIC guidelines from the UK.
Some really robust data in there.
Absolutely. We also have peer-reviewed data on energy-based treatments from the Dove Medical Press and some highly detailed expert clinic FAQs.
Which really help break down the practical application of all this.
Yeah. So our mission today is to explore a medical connection that completely blew my mind. We're going to look at how a chronic respiratory issue like asthma or a smoker's cough literally dictates the treatment strategy for vaginal laxity.
It's a brilliant case study in systemic medicine, honestly.
Yeah, so.
Because if a practitioner tries to treat a patient's pelvic health without evaluating their chest health, they aren't just going to fail, they might actually cause permanent structural damage.
Which is terrifying.
It really is.
But I want to make sure we understand the landscape before we get into the treatments that can go wrong. I was looking through the clinic FAQs, and they're extremely careful to separate the terms vaginal laxity and pelvic organ prolapse.
Yes, that distinction is crucial.
I honestly always thought those were just two ways of describing the exact same problem.
You're definitely not alone in that, but confusing the two is where a lot of bad treatment plans actually start.
Oh, really?
Yeah. So vaginal laxity is fundamentally a subjective sensation. The patient feels a distinct looseness.
Okay, so it's about how it feels to the patient.
Exactly. The vaginal lining is packed with collagen and elastin fibers. That's what gives the tissue its stretch and its ability to, snap back.
Like a rubber band.
Right. And when those microscopic fibers get damaged, the structural support weakens. Patients report reduced sensation, or they say things just don't feel as compact.
Okay.
But a doctor can do a pelvic exam on someone with severe laxity and find absolutely nothing anatomically out of place.
Wait, really? So laxity is strictly about the health and tone of the tissue itself? What makes prolapse different then?
Pelvic organ prolapse, or POP, is a physical, measurable failure of the pelvic architecture.
Okay.
The organs themselves, the bladder, the uterus, or the rectum, they literally drop down from their normal positions and bulge into the vaginal canal.
Oh, wow. That sounds intense.
It is. And we don't just rely on sensation for this. Doctors measure the exact descent using a highly standardized topographical mapping system called the POPQ scale.
So you can have laxity without prolapse.
Exactly. But if laxity goes untreated, it often paves the way for prolapse.
Okay, let's unpack the core mystery here. How on earth does an irritated throat or chronic bronchitis reach all the way down to cause that kind of structural failure in the pelvis?
It all comes down to the physics of intra-abdominal pressure.
Okay.
I want you to visualize your human torso as a sealed, pressurized canister.
A canister. Got it.
The top lid of the canister is your diaphragm. The sides are your abdominal muscles. And the flexible base holding everything up is your pelvic floor.
Right. So it's all contained.
Exactly.
Yeah.
When you take a breath and cough, that isn't just a throat spasm. Your diaphragm muscle violently thrusts downward to force air up.
Okay.
And because your abdominal walls automatically tighten during a cough, that massive spike in internal pressure has nowhere to go but straight down.
Oh, I see.
It slams directly into the pelvic floor muscles and the connective tissue of the vagina.
I'm trying to picture the sheer mechanics of that. I assume if I just clear my throat right now or, catch a cold for a few days, that isn't going to destroy my pelvic floor, right? We're talking about chronic, relentless pressure.
Precisely. A healthy pelvic floor is designed to handle temporary spikes in pressure. It's incredibly resilient.
Right. It's built for daily life.
Yeah. But the clinical guidelines from Dr. Kevin Stepp and the Women's Health Clinic specifically categorize chronic coughing as a primary strain factor.
A strain factor.
Yes. They group a chronic cough right alongside severe obesity, and repetitive heavy lifting.
Wow. Okay, so a single cough is like jumping on a trampoline. The fabric stretches, you bounce up, it snaps back, no harm done.
Perfect analogy, yeah.
But a chronic smoker's cough. Well, that's like taking a 50-pound bowling ball and just dropping it onto the exact same spot on the trampoline 500 times a day, every single day for a decade.
That is a great visual, but let's push it a bit further.
Okay.
It isn't just about the trampoline fabric stretching. It's about the springs holding the trampoline to the frame starting to warp and snap.
Ouch. Yeah, that makes sense.
The continuous repetitive loading physically breaks down the collagen matrix. The tissue never gets a sustained period to repair itself.
Because the pressure just keeps coming.
Exactly. So over time, that relentless downward force essentially stretches the tissue until it cannot snap back, creating laxity and eventually pushing the internal organs down into a prolapse.
So if a listener goes to their doctor complaining about this sensation of looseness, what is the standard protocol? I assume the first line of defense isn't major surgery. Do they just send you to physical therapy?
For mild to moderate symptoms, yes. Conservative care is always the starting point.
Okay, that's reassuring.
That usually means pelvic floor muscle training, which most people know as Kegel exercises.
Right, Kegels.
The goal is to hypertrophy, or thicken, the muscles that act as the supportive sling for the pelvic organs.
But looking at the NHS and the Royal College of Obstetricians and Gynecologists guidelines, if you just do the physical therapy and ignore the chronic cough, you're essentially sabotaging your own recovery.
You are. The guidelines are adamant about this.
They don't sugarcoat it.
Not at all. Treating a chronic cough, whether that means prescribing better asthma inhalers, quitting smoking, or managing acid reflux, is a mandatory fundamental component of pelvic care.
Because otherwise the math just doesn't work.
Exactly. You cannot outtrain a chronic mechanical overload. If a patient does 20 minutes of perfect Kegel exercises every morning, but then spends the rest of the day violently coughing, the net mechanical force on the pelvis is still overwhelmingly negative.
So going to a pelvic floor therapist who doesn't ask about your lung health is like trying to bail water out of a sinking boat without actually plugging the hole in the hull.
The boat analogy is popular, but honestly, if we connect this to the bigger picture of intra-abdominal pressure, it's more like a pressure cooker.
Oh, a pressure cooker. I like that.
Yeah, you can reinforce the metal sides of the pot all you want with Kegel exercises, but if you don't turn down the heat source, the chronic cough, the steam pressure is eventually going to blow the lid off.
That makes total sense.
Failing water implies a slow leak. A chronic cough is an active, violent, repeated pressurization.
Right.
The medical silos that separate respiratory therapy from gynecology completely fail patients in this scenario.
They really do. But let's say conservative treatments just aren't cutting it.
It happens a lot.
The patient is doing the exercises, but their asthma is notoriously hard to control. Or, quitting smoking is a slow, ongoing battle. The laxity is ruining their quality of life. The next step up is usually clinical energy-based treatments, right? Using lasers or radiofrequency machines.
Right. These have become incredibly popular because they're non-surgical outpatient procedures.
Which sounds ideal.
It does. The general concept is to apply targeted energy, either light or heat, to the vaginal walls. This creates controlled microtrauma, which tricks the body into launching a localized healing response.
So you're basically kickstarting the body's own repair system.
Exactly. The body rushes new blood flow and fresh collagen to the area, which firms up the tissue and reverses that loose sensation.
But the Dove Medical Press study in our sources throws a massive wrench into this.
A huge wrench.
It turns out that the severity of your cough literally dictates which specific machine a doctor should use on you. You can't just pick whichever laser the clinic happens to have on hand.
And that is exactly the trap many clinics fall into. The Dove medical study clearly demonstrates why that's a massive clinical error.
What did they look at specifically?
They ran a head-to-head comparison between transvaginal CO2 laser therapy and AI temperature-controlled radiofrequency, or RF therapy.
And how did they measure the severity of the problem? Because looseness is subjective, like you said earlier.
This is where it gets very scientific. Because a chronic cough exerts so much downward force, vaginal laxity is very frequently accompanied by stress urinary incontinence, or SUI.
Right.
That's when urine involuntarily leaks during a pressure event, like a cough or a sneeze. To get an objective measurement of the tissue's failure, the researchers used a 1-hour urine pad test.
Wait, they literally just weigh a pad.
Exactly. The patient drinks a specific amount of water, puts on a pre-weighed absorbent pad, and then spends an hour doing provoked activities.
Like what?
jumping jacks, coughing, climbing stairs. Then they weigh the pad again to see exactly how many grams of leakage occurred.
That's so simple but so effective.
It is. Mild cases leaked about 2 to 5 grams. Moderate was 5 to 10 grams. And severe cases were leaking anywhere from 10 to 50 grams of urine in a single hour.
Okay, so that is a highly measurable, undeniable metric. When they compared the laser against the radiofrequency device, what did the data actually show?
It revealed a massive divergence in long-term durability.
Really?
Yeah. At the 6-month checkup, the CO2 laser was incredibly effective for the mild cases. It hit an almost 90% success rate, whereas the radiofrequency was hovering around 70%.
So for a patient with just mild laxity, the laser provided a very rapid, highly effective fix.
Precisely. It works great short-term for mild issues.
But we're talking about patients with a relentless chronic cough. That pressure stack doesn't go away. So what happens at the 12-month mark for the more severe cases?
The laser success rate literally collapses.
Collapses.
Yes. For patients with moderate to severe symptoms, the exact kind of patient a chronic cougher becomes over time, the CO2 laser dropped to just a 40% effectiveness rate at 1 year.
Wow. That's a huge drop.
It is. Meanwhile, the AI-controlled radiofrequency maintained its durability, holding steady at around 70% effectiveness for that same severe group.
Okay, why the massive drop-off? What is physically happening differently between those two machines?
It comes down to how the energy interacts with the tissue. The CO2 laser is ablative.
Meaning it burns.
Essentially, yes. It vaporizes the water in the superficial surface cells of the vaginal wall to create those micro wounds.
Okay.
The radiofrequency device is entirely different. It uses electromagnetic waves controlled by AI to bypass the surface altogether, heating the deeper submucosal layers without burning the top layer.
Okay, let me see if I have this. The CO2 laser is like sanding down and refinishing the top coat of a hardwood floor.
I like where this is going.
It looks flawless and tight initially, but if you have heavy furniture, which in this case is the chronic cough constantly dragging across it, that thin surface repair gets ruined very quickly. The radiofrequency is more like going down into the basement and reinforcing the actual floor joists beneath the wood. It takes a bit longer to see the result, but it can actually bear the structural weight of the cough over the long haul.
That is a brilliant way to conceptualize it. The deeper tissue remodeling from the RF creates thicker, more robust bands of collagen.
Which you need if you're coughing all the time.
Right. The ablative laser creates a more superficial fix that simply cannot withstand the daily, violent mechanical strain of a persistent cough.
Which brings us to a case study in the NICE guidelines that genuinely shocked me.
Oh yes, this case study is a wake-up call.
Let's say a listener has a bad smoker's cough. They decide to get the quick fix CO2 laser to handle their laxity. But the cough persists, the laser fails at month 12, and the downward pressure eventually forces the organs into a severe prolapse.
It happens more often than you'd think.
At that point, they need major reconstructive pelvic surgery. Can't the surgeon just go in and fix it mechanically?
This is a critical safety warning that patients are rarely told about.
Yeah.
The NICE guidelines, the National Institute for Health and Care Excellence in the UK, highlighted the case of a 39-year-old premenopausal woman.
Okay.
She had a chronic cough, a positive stress test, and stage 2 organ prolapse. And she opted for the transvaginal laser treatment.
39 is incredibly young to be dealing with stage 2 prolapse. So she gets the laser. What happens next?
1 year later, her anatomical prolapse had worsened so much from the ongoing pressure that she required a posterior vaginal repair and the insertion of a synthetic tape sling.
Oh, wow. So a major reconstructive operation.
A very major one. But when the surgeon opened her up, they noted that her vaginal mucosa was, quote, very thin, friable, with loss of rugae.
Whoa, pause.
Yeah.
Friable. Loss of rugae. That sounds horrifying. What actually happened to her tissue?
Friable is a surgical term meaning the tissue is incredibly fragile.
Like it falls apart.
Yes. It tears easily, it bleeds on contact, and it literally crumbles when the surgeon tries to manipulate it with instruments or suture it.
That's terrifying. And what about rugae?
Rugae are the natural accordion-like folds of the vaginal wall that allow it to safely expand and stretch. She had lost those folds entirely.
Because of the laser.
Because of the combination of the laser and the chronic cough.
Oh, I see.
The ablative laser fundamentally altered the architecture of her tissue, replacing healthy elasticity with a stiffer, scarred response.
And then she kept coughing.
Exactly. When that stiffer tissue was immediately subjected to the constant, violent downward pressure of her cough, it didn't heal normally. it became brittle.
Wow.
Because her tissue was so friable, the reconstructive surgery was incredibly difficult and resulted in far higher blood loss than a normal patient.
That is the ultimate trap. By trying to get a quick surface fix for the looseness, knowing she had a bad cough, she accidentally destroyed the exact tissue the surgeon needed to use to save her organs later. She burned the bridge.
She did. If you have a respiratory issue that you cannot immediately resolve, opting for an energy-based treatment isn't just a risk of the treatment failing. It might actively complicate and endanger your future surgical options.
This is terrifying for anyone dealing with chronic bronchitis or stubborn asthma.
That's a lot to process for sure.
If reconstructive surgery is risky and lasers are risky, what is someone supposed to do right now when they feel a coughing fit coming on? How do you protect that internal pressure cooker from blowing the lid?
Thankfully, the sources from the Pelvic Floor Center provide highly specific active defense strategies.
Good. We need some good news.
The primary behavioral shift is adopting something called the active cycle of breathing technique.
How does that actually work mechanically? Because a cough feels like an involuntary reflex. How do you just, change how you cough?
Well, a traditional cough involves taking a breath, tightly closing your glottis, your vocal cords, and then violently forcing air against that closure until it bursts open.
Right.
That explosion is what causes the massive downward pressure spike. So the active cycle technique replaces that. It involves phases of controlled, deep breathing to expand the lungs, followed by localized huffing.
Huffing, like fogging up a mirror.
Exactly like that. You force the air out with your mouth and throat open.
Oh, interesting.
Because you aren't closing the glottis to build up explosive pressure, you can still effectively move mucus and clear the chest, but you dramatically reduce the downward mechanical force on the pelvic floor.
That is such a simple but brilliant hack.
It is. Respiratory physiotherapists teach this specifically to protect the body from repetitive strain.
Okay, so that changes the air pressure. But what about the pelvic muscles themselves? Can you actively brace for impact?
You can and you absolutely must.
How?
The clinic guidelines prescribe a daily regimen specifically designed to act as a counterforce to chronic coughing. They recommend a routine of 10 fast lifts and 10 slow lifts of the pelvic floor performed 3 times a day.
Let me make sure I understand the physiology of that. Why the difference between fast and slow?
It's about training different muscle fibers for anticipatory control. The fast lifts train your fast twitch muscle fibers.
Okay.
You need those muscles to react instantly, firing in the millisecond before a sneeze or a cough hits to create a rigid barrier.
Like slamming a door shut before the wind catches it.
Exactly. And then the slow lifts, where you hold the contraction, train the slow twitch endurance fibers. Those are what keep the internal organs suspended in their proper anatomical position throughout the rest of the day.
So you're basically rewiring your neuromuscular system.
You are?
You're training your body so that the moment your brain signals a cough is coming, your pelvic floor automatically engages like a shock absorber before the pressure wave even hits it.
Exactly. It requires active daily training, but it's the only way to safeguard the structural integrity of the pelvis while you and your doctor work on resolving the underlying respiratory issue.
This has been an incredible journey through the human body today.
It really highlights how connected everything is.
We started out looking at vaginal laxity, which, seems like a hyper-localized tissue problem. But by unpacking the sources, we've discovered it's actually a full-body physics equation. The health of your lungs is quite literally the foundation of healing your pelvis.
It proves that we have to stop looking at symptoms in isolation.
100%.
The entire decision tree, whether a patient should use conservative Kegels, a quick-fix CO2 laser, a deep-heating radiofrequency device, or prepare for complex reconstructive surgery, hinges entirely on the mechanical pressure generated by their chest.
It really is that interconnected. And that brings us to a final thought for you, our listener, to mull over as you go about your week.
A little homework.
Exactly. We've just explored how something as mundane as an everyday cough symptom most of us ignore or just, live with, has the sheer mechanical power to literally reshape internal pelvic anatomy, override high-tech medical lasers, and dictate the danger level of a surgery years down the line.
It's pretty sobering.
It is, so ask yourself, what other seemingly minor everyday habits or easily ignored aches and pains are secretly rewriting the structural integrity of your body right now?
Something to think about.
Definitely. Until next time, keep diving deep.